Hello and welcome everyone to another PEDro World-Wide Journal Club. Today we'll be discussing a three-armed randomized control trial comparing cognitive functional therapy with and without movement sensor biofeedback for patients with chronic disabling low back pain versus usual care. This is published by Peter Kent and colleagues in the Lancet. And today we have 5 panel members with a mix of experienced researchers, clinicians, and a consumer. So we'll go around first and introduce everyone. I can go first. My name is Josh Zadro. I'm a Senior Research Fellow at the University of Sydney, and I'm also on the PEDro Education and Training Committee and used to work clinically as a physio.
I'm Chaturani. I'm a PhD student at University of Sydney, and also I'm from background a physiotherapist.
My name is Jayden Smileski. I'm a new graduate physiotherapist working for New South Wales Health, and I'm a clinician member on PEDro.
I'm Peter O'Sullivan. I am a professor of physiotherapy at Curtin University, West Australia, also a practicing clinician, and I was involved with the Restore trial.
Hi, my name is Joe. I am a ex-back pain sufferer and a consumer of the both traditional physiotherapy practice when it comes to back pain, as well as CFT when it comes to back pain.
So the first question is, I guess, discussing what the clinical implications of these findings are. And I might throw it to Jayden as a new grad physio to kick off the discussion.
So I think the clinical implications for this trial is that it's reassuring to know that there's a method to address back pain in the community. Working in an outpatient setting, there's a lot of people coming in with chronic low back pain. So it's really good to know that there's proven methods and results out there that can help people recover from their back pain.
What you highlight, Jayden's correct, that we know that back pain is a massive problem. It's the biggest leading cause of disability in the world. And we've had quite limited evidence for interventions that have particularly sustained effects. And so the Restore trial was kind of like a relatively pragmatic trial nested in primary care with a pretty disabled group of people and many of them had just given up on care. They'd been through the system, had had a lot of treatment, and had kind of lost hope. And I think it gives hope both for patients as well as for clinicians that actually, even though you can have chronic and disabling pain that can be incredibly disruptive in your life and distressing, there's hope for recovery, and that pathway to recovery is different for different people. But actually teaching people to learn to self-manage their pain is the key. And it's a different way of working and thinking that I think we've been taught traditionally to operate as clinicians, as physiotherapists.
Yeah, and also I think, as stated in a trial, the competent-based training program are essential to ensure effective implementation and also to equip physiotherapists with the necessary skills to offer CFT is important.
Yeah, I think that's really important.
Yeah, so I guess, Joe, with that segue, it'd be good to hear about your journey for when you had back pain and what you tried, and then kind of what led you to CFT and I guess the outcomes that you had.
Yeah, so I mean, I guess from my point of view, I tried pretty much everything. I had a pretty standard story where I had an injury that then didn't really get better. And it didn't get better at the sort of rate that I expected it to. So because of as Peter said, like the back pain can be incredibly debilitating. And because, I couldn't work and I couldn't play, it was a very meaningful injury. And from that, it led to a bit of fear and a bit of stress. And for me at that point, I sought some help. And I was just constantly getting bombarded. While I was trying to seek help and trying to get better, I was constantly being bombarded with these really negative and damaging messages regarding back pain and damage and just pain in general. And I think on top of that, everyone gets bombarded with these damaging messages every single day, whether you're injured or not, regarding how fragile backs are. Every workplace I've ever worked at, there's always been, lift with your knees, lift with a straight back, lift with this, like don't lift anything over 15 kilos, don't twist. And so we're sort of already preloaded to think that our backs are fragile. And then, I went to a chiro and got told, that I was out of alignment, and the only way I was going to get better was with constant treatment. I went to a physio who told me to, keep my core braced whenever I was lifting anything up, to keep my back straight, to keep, essentially just keep everything very rigid and move quite robotically. And it just continuously sort of fed this belief that I was damaged and that pain meant damage, and that to get better, I had to keep avoiding things and to keep essentially just be careful. Otherwise, I was sort of going to wear myself out. And then this led to over a number of years, this sort of led to me becoming much weaker, less flexible, deconditioned, very fearful of my pain. I held the belief that the pain meant damage so strongly at that point that essentially anything that caused pain, I would then avoid. And by the time I ended up starting my CFT journey, I was in a pretty bad place. I couldn't do anything without pain. I thought about my back every single minute of every day. I couldn't even lift the toilet seat, without pain. And, I was squatting down using my legs and keeping my back upright just to lift a toilet seat. And I was like, this can't be right. And, so it just all fed into itself and became a monster. And I was in a pretty bad place about 8 years ago or 9 years ago. So, yeah.
So what about the second half of your journey, Joe?
But the second part of the journey was quite different for me. So I've got this, I drew up a little pain cycle where I was with the previous treatment. And this is where the belief was that pain equaled damage. And so I'd get a stressor, I'd get pain, I'd feel like the pain meant damage. My fear and my stress would go up. I'd protect, I'd avoid. My stress would go up further. My mood would decrease. My pain would go up. I'd reduce activity, and then that would just feed into itself. So in the second half of my journey, I guess I needed to be retrained that pain didn't necessarily mean damage, and that belief that the pain and damage were completely connected was actually stopping me from doing a whole bunch of things that were really important to my recovery. And so essentially, the second half of the journey, I'd get some stress and that would flare up pain. But then I would remember, or I was told, I was convinced by my practitioner that pain didn't equal damage. So then instead of then being fearful and more stress, that would sort of stay the same. And then I was empowered to then engage in safe movements, to meditate, to breathe, to engage in activities that were distracting. And from there, the stress would go down instead of up. My mood would get better. My pain would then go down. It would further decouple the idea that pain and damage were so strongly linked. And then from there, I was able to increase activity, get stronger, get more flexible, and go through that cycle a number of times. And eventually you can recover. You can recover in a way that you just never thought possible, which is what happened to me.
And I think and it'd be interesting to hear your thoughts on what do you see CFT as an intervention from a patient perspective? Like, what for you was the active ingredient of this program of treatment?
I am ashamed to say that I actually to this day don't even really understand what CFT is. All I know is that absolutely everything that I got told previously to working with the practitioner who got me into the CFT journey, everything just seemed completely opposite. Prior to CFT, I was told that I was damaged, that pain meant damage, that I had to protect, I had to avoid movements, I had to reduce bending, twisting. And after the CFT, I was told to relax and move, that pain didn't mean damage, that all these movements that I'd completely cut out were actually safe, and not only safe, but were actually key to my recovery. I remember a number of times I had my back compared to, say, an elbow. And previously I was sort of always told that whenever I was going to use my elbow to brace it and hold it really tough and, keep it in the same position and never move it. And then, at the end of 3 years of doing that, you have a pretty sore elbow. And the same was true. And so it was just, you do that with your back every day without even thinking about it, because that's what we're told to do. But with the CFT journey, I was actually told, no, relax, trust that pain doesn't mean damage, trust that, your pain is more linked to stress than it is to physical damage and findings on scans. That finding on scans, where I was told a whole bunch of horrible things, are actually just normal age-related change, and that there are plenty of people with those findings that don't actually have any pain at all. So it just further decouples that idea that pain and damage are linked. And then from there, you can start to engage in things that are meaningful to you and reduce your stress, reduce your anxiety, reduce the meaning of the pain. And people can put up with a whole lot of pain. It's the fear is for tomorrow. You sort of, if that pain doesn't mean that tomorrow you're more damaged, or that in 5 years' time you're going to have to give up what you love, then the pain sort of loses its hold over you, and then you can then further just live, and eventually you forget it was ever there in the first place. I remember being told, because I used to think about my back every single minute of every day, and I remember being told, no, we're going to get you playing tennis, we're going to get you surfing, we're going to get you doing all this stuff, and you won't even think about your back. Which I thought, no, come on. I didn't think that was actually possible. And then, a couple of years later, and it was, I don't think about my back. I do all these things, I don't think about it. I have flare-ups every now and then, which are debilitating and take me way back. And, they still get the fear and the anxiety going. But then, you follow the routine that, I know what to do. I've been given the ingredients, and I've been given the recipe to sort of be in charge of my own recovery, which before it was always, you'll have to come back 3 times a week. Whereas it seemed like with CFT, the power was really put in my own hands for my own recovery, which was something very different and, very empowering.
Yeah, it's fascinating to hear your perspective on what the treatment is. It sounds like it instilled a lot of confidence in you, addressed any misconceptions that you've had from previous management, and was kind of just a get on with it sort of thing, move the way you should.
And I think just on that, I think highlighting that it's a really tough journey as well. It's like, it sounds very easy to kind of go, well, we just get you moving and get back to where you were. But when you're frightened and when you've got pain and your whole system's ramped up and you're stressed and you've lost hope, it's really, really hard to create that shift. And I don't know how hard it was for you, Joe, to create that kind of, not just a mindset shift, but a whole behavioral shift as well.
I actually think that it would be impossible to achieve without that support of a practitioner that really believes in what they're doing and really believes in the evidence and that constant encouragement. I actually don't think that this is achievable. I mean, to go from where I was to where I am now, I mean, it does take help, and I don't know if I could have done it on my own. But then, that being said, like once you have the tools, you then are doing it on your own. So I don't know, but I think this is the hardest thing, I think, for a practitioner giving CFT is you're trying to dismiss a patient's pain, or not dismiss it, but dismiss its meaning, while ensuring that consumer of that CFT is completely heard and validated, because the experience that they're going through is unbelievably real, but the pain itself is so complete. It's just, it's hard.
So I think I can touch on that point as well in terms of the experience and the confidence of the clinician. I think I've tried in myself as a new graduate to implement some of these principles and strategies into my own patients with chronic back pain. And I think it is really challenging to shift that mindset and shift that belief when you haven't got that experience of knowing the right things to say and how to get that message across in the right way. I think it's easy to have that background knowledge and that real scientific knowledge on the right processes and why it works, but to get that message across to the patient in a way that they understand, in a way that means something to them, I think that's really important to learn and become comfortable with.
And just on that, around the training journey, we copped quite a lot of criticism in the trial because it was people were like, oh well, this is too much. There's too much training. It's not realistic. And I'm like, well, how much does back pain cost the community? How long does it take for a neurosurgeon to do spinal surgery? How long does it take for a manual therapist to learn to manipulate the spine? Interventions that are actually not that effective for chronic low back pain. This idea that you can just go to a workshop and learn how to help someone like Joe through that journey, it's crazy. So this idea of training knowledge, which I think Jayden, you highlight, you have to have the knowledge, right? But then you train the skills, and that's both skills around communication, building trust. And I think you highlight that, Joe, that sense of like validation of listening, deep listening, of understanding the person's concerns and worries and their goals and expectations. And then skills around building confidence, building back in the body, of like taking back people back to really fearful movements and activities that often the clinicians frightened. And we saw this in the training journey where the clinicians themselves were pushed right outside their comfort zone, doing exposure work of taking patients who are really frightened and distressed back to feared and avoided activities. So the clinicians themselves described this kind of behavior change journey themselves that they were going through around their own beliefs and behaviors, but actually building their own confidence to engage differently in the way they worked. And the other one that was commonly reported by clinicians is this, oh my God, I have to do something. Like we have this idea as physiotherapists that if we don't treat the person, we don't lay them on the bed and push on their back, we're not treating them. And we have this idea that if we don't do it, the patient won't think they've been treated. But there's a whole different mindset around what does the person actually want? And patients want to know what's going on, but they want a pathway to recovery to reach their goals. And I think that's a really big shift in terms of how we've been training physiotherapists to go, actually, as a whole mindset shift around the way we behave, the way we think, the skills that we have. They're a broader skill set to empower the person to take ownership over their own health condition. That's not easy, and not everyone hits competency at the same time point. But it's a tough journey for patients. It's a really tough journey for clinicians.
And what would you
It's
recommend in terms of training, Peter? Because I think when I was practicing, I was kind of in Jayden's situation as well, where you see the CFT principles. I never did a course or anything like that, but you kind of pick up bits in here and implement, bits and pieces of it. Would you recommend people do that, or is it vital that they get the
think it's
appropriate
mandatory.
training?
Yeah, and I think, we talked about this in the recent systematic review that was published in Physical Therapy Journal around looking at training to competencies. And I think, other professions do this. I don't think we've been very good at doing that, but actually to say, what are the core competencies that we have to train people to, and then we have to test that they're competent. So what was quite important in the Restore trial, which actually isn't that common in clinical trials, is we didn't let the physios go into the trial until they could demonstrate all of those core competencies. And then we did fatality checking to make sure they were still competent while they delivered the intervention, because we know that clinicians drift, basically. So coming back to your question, after the Restore trial came out, we had, I think, clinicians from about 84 countries contact us going, how can we get this training? So, our team have developed this online training program called Evolve Pain Care Academy, which essentially is a social enterprise, which provides supported training for clinicians, but it's also got a hub for patients as well. Like stories of Joe are up on that website, and others who have who described their journey, infographics, because the other thing that we know is that we need resources for patients to do homework as well. It's not enough to have a session and just go home and they're caught back in that whirlwind, is to go and read and listen and see the videos of other people who've been through that journey to build their own hope. So that's why we have created that that website. And I think the concepts around CFT are aligned to the guidelines. They tick all the boxes around good care, but actually the practice of it is something that takes mentoring, skill development and mentoring to develop those competencies. And we're not apologetic to that, because we think it's hard, and we're dealing with a really tough problem that we just haven't been effective at managing. And so it doesn't come as a surprise that it's not something you can do in a 2-day workshop.
Chaturani, what's your experience being you were previously a lecturer in physio in Sri Lanka? What are the main things that are taught there? And is things like CFT acceptable and used over there, or is it different?
No, I think it's not common in Sri Lanka. I don't think it's like common in any other low middle income country. I think the patient expectation will be a big issue, because like many patients with low back pain expect like quick fixes. They want a scan to fix their problems, passive movements like massage, injections to fix the pain. But CFT challenge these expectation. It needs some time and also communication to build motivation. And also in terms of physiotherapy perspective, I think it needs some cultural change in physiotherapy, because like they are not used to that. So it might take some time, and also some supervision or the mentorship to guide them is essential, especially for a low middle income country setting.
And in your appointment, so you mentioned time and patient expectations. Do you see a difference in the expectations patients here have any experience, or is it
Yeah, I think so. Because like in Sri Lanka and other low middle income countries, like the electrotherapy is quite common. So like they see like something is happening, the lights on. But like, yeah, so once it comes as CFT, like they don't see it as a treatment. So they might be expecting a treatment. Yeah, so it needs some changes in, the expectations and the cultural change.
I'd love to get Joe's perspective on that, because you probably had the old style kind of treatment, which is more the hands-on, Joe. And how acceptable was that to have something that was quite different? I suppose I'd be interested to know what your thoughts are.
Well, I think by the time I started CFT, my experience with the more traditional treatments was quite extensive, and I was still in pain. So I'd sort of I guess I wasn't looking for more of the same. I was looking for, I guess, something different. For me, the fact that I went into the CFT and it was completely different, and it was challenging, and it was confronting. I mean, at that stage, I was willing to do anything to get fixed, to just get a little bit better, that I was sort of willing to look under any rock that I could find. And then from that first appointment, which I'll touch on a little bit further in a sec, but my recovery was so fast, and it was so profound, and I was making such good ground so quickly that it was irrefutable to me that I was on the right path. I knew I was on the right path, and it just built upon itself, and then almost in a way that I spiraled down and lost everything that I sort of was doing, and all my activities. It came back in the same way, and just seemed to reverse itself. That I was pretty convinced pretty quickly that that maybe the massages and the needling and the chiropractic adjustments maybe weren't everything that they were cracked up to be. And I mean, I think everyone's different. Maybe those things do have a place for some people, but they didn't for me, and they didn't help me in a meaningful way. And the CFT did, and being given the tools to sort of manage my own recovery and put myself back in the driver's seat was hugely effective for me.
And what was that first appointment like? You mentioned, so like when the physio didn't put their hands on you or didn't try and do any of flashy gadgets?
My first appointment, sorry, was part of a training workshop. So I did my first appointment in front of about 50 other physios. And I think the biggest thing that stuck out to me in that appointment was, well, apart from how different it was, essentially I was asked to list all the movements that I was scared of and fearful of and that I couldn't do. And then essentially, one after the other, we did those movements while I was continuously reminded that these movements are safe. You are not going to do yourself any damage by doing these movements. These are actually key to your recovery. But what I remember is looking at all the other faces of the physios in the room, seeing that their jaws were on the floor, thinking that this guy was about to kill me. He was going to do me more damage than help. And so I think this sort of comes back to practitioner confidence, and that is that, I mean, everyone gets into physiotherapy, I believe, because they want to help people. They want to help people get better. They want to help people with their pain. But they're as a result of that, physiotherapists fear doing more damage to a patient. And I think that sometimes that fear can actually get in the way of delivering a meaningful treatment, because the idea that pain and damage are linked is not actually, it's not just prevalent in patients. I think practitioners do have those beliefs as well. So until we can empower not just patients, but also practitioners to deliver this stuff and be confident in it and deliver it in a way where they're able to take away the patient's fear, because you're asking, I was being asked to do stuff that I found absolutely terrifying. And if I wasn't being reassured by someone who at the time seemed to have all the confidence in the world, then I'm sure that wasn't just a facade. But if I was being told to do all these terrifying things by someone that seemed terrified themselves, it would sort of, I don't know, it would take away the ability for that to be a helpful intervention. You know, if I was being told to bend over and pick something up and round my back, which I hadn't done in a couple of years, and the person asking me to do that was like, oh, I don't know what's going to happen, that would be absolutely terrifying and non-helpful. Whereas I was being told, bend over, pick this up. I assure you this movement is safe and healthy and good for your back because your back needs to move. It was made all the difference. And it was almost a complete change in mindset from my back needs to be protected to my back actually needs to be used.
Joe was talking about how the person in front of him was very experienced and confident in their recommendations. Have you, I guess, as a first year physio working, have you experienced any backlash towards the approach when you're trying to give, bits and pieces of CFT to your patients? And I guess the broader question for the group is, are there certain populations that maybe CFT is more or less appropriate for?
Yeah, I've definitely had some challenging times trying to get some of these principles across. I can specifically think of one encounter I've had where I've tried to pursue a lot more of the education route. So this patient had a lot of negative beliefs behind their back pain, mentioning through some of the imaging they had, there's lots of arthritis, and this is something that they just have to live with. They know this is a disability and they just have to get on. And I tried to reassure them, go through all of the things that I know I should be doing, explaining that these are common findings in the normal population. And, when you're thinking positively and doing things you enjoy, some of those positive activities can help manage your pain. But I got quite a lot of resistance to what I was trying to portray. And it could be just the way I'm getting it across maybe wasn't how they would have liked to have heard it or how it should have come across. But I've definitely found there is some resistance in certain people when you're trying to bring across these ideas and principles.
So can I just flip that back to you, Joe? Because you were told you had a back of a 60-year-old, right? You had fissures and degeneration and disc bulges and arthritis. Am I right?
Yeah, I was told all of that. I think I was late 20s at the time when I said that I had a pretty good back of a 60-year-old, which is one of the things that really led to that pain damage message being very uh, cemented in me. So I do get what you're saying though, Jayden. Like, it is a really hard. I mean, essentially, you're trying to dismiss uh, the person's pain without dismissing them as a person, which is really, really hard to do because you know it's the number one challenge that you guys are going to face going through this CFT journey is that people are in an incredible amount of pain. They're in debilitating pain. A lot of the time they'd be classified as disabled, and they believe that there are very good reasons why this pain exists, other than that that they have pain linked to painful memories, pain linked to movements that have been painful in the past, so they believe them to be painful. They're more likely to be painful. Pain linked to stress, pain linked to, but everyone believes that their pain is actually linked to damage until they're educated otherwise. And I think that, I mean, there's a whole lot of stuff, I think, around knee arthritis these days where they're like, okay, yep, you have knee arthritis, but your knee is still going to be a better knee if you move it and it's strong. So it's like, okay, all of these findings that you've got on your scan of your back are, I mean, they're there. We can't say that they're not there, but it doesn't necessarily mean that you have to be in this incredible amount of pain. And even with those findings, if you somehow find a way to get through to the patient and enable them to move and get strong and believe that they can improve, then even with those findings, people can actually do some incredible things and be pain-free. They can get back to living. And those findings might still be there, but they're not actually the reason behind the pain. But I think it's about notching up. And I'm not trying to trivialize what is a really big challenge, but I think it's about notching up a couple of wins early, unlocking some movements. So, I mean, in my case, there were 20 movements that I was scared of. Pick 3 that are incredibly safe, that there is no chance of damaging this person by doing these 3 movements, and show them that these movements are not only safe, but they actually feel good, and it feels good to move, and that the next day you can do those movements better. And then once you've done those 3 movements, go after a couple of others. And then once you've done them, just chip away at it, because I think everyone, no matter how damaged they are, you can always improve. And once you've started those small wins, then perhaps sky's the limit, and you might actually find that person that was disabled that can get to a full recovery.
And I think what you highlight, Joe, is key. Like, CFT is very much about behavioral learning. It's not so much about sitting down and educating someone out of pain. It's
Show
about
them
the behavioral process. So we don't do any education until we've gone through the behavioral process. So the education is just sense making, which is why we don't call it education. Like, the 3 pillars are making sense of pain, and that making sense process comes after the behavioral process. So we wouldn't take someone who's got damaging reports and go, actually, let me explain the natural history of pain, and it doesn't mean that. We'd go, let's explore how movement is for you. Let's take those movements, like Joe said, and get you back moving again, and then reflect back to go, hey, what does that make you think? You're actually moving and feeling better. What does that tell you about your back? And like, oh, maybe I'm not quite as damaged as I thought. It's like, yeah, that's right. So instead of it creating an argument between the patient and the clinician, it actually is a partnership of like, let's take the things that are important for you. Let's explore them. Let's see what your experience is, and then let's validate your experiences, and let's reflect back on what you think is going on. And you often see there's a mismatch between their experience and their beliefs. So they have to update their belief, because experience will always trump belief. always. And so that's why the experiential learning is such a critical component of this intervention. And I think, you hit that right on the head, Joe.
And Peter, it'd be interesting to know, like, do you think there are presentations where you wouldn't provide CFT, or are there certain personality types that you identify that you just know it's not going to fly?
It's a really interesting question, and we've looked really hard on this. So you might have been familiar with the moderation paper that came out that Mark Hancock led, and we were looking in that to go, who aren't we reaching? The thing that was really helpful in that moderation analysis was that the people who benefited the most were the most disabled people, which are the people like you were stuck in that cycle, Joe, who need our help, which we haven't been able to help these people historically very much. That wasn't to say that the least disabled didn't benefit, because they did. We actually couldn't find who didn't benefit. So we looked at things like pain catastrophizing, pain-related fear, pain self-efficacy. We also looked at things like cognitive flexibility, people who couldn't change the way they think easily. We saw a really faint signal on that, but it was lost later. What we're seeing, we've got some qualitative work that's underway at the moment to look at so-called responders and non-responders to kind of get an idea of the person experience of like who hasn't got better. The kind of sense that we're hearing, from our own clinical experience, there are some people who just carry such a huge burden in their life. It might be early life trauma, it might be a lot of social stresses. Those people, it does take a partnership. And so we do know that patients come to this saying, I want to take this journey. You have to have a willingness to embark on this process. You can't come to it going, I want you to just fix me, because this is not about fixing you. But I think, naturally, when you've gone through a journey like Joe, which many of our patients have, right? A lot of people just give up or try all these different things. You're not looking for more of the same. And I often hear this. People go, oh, you're bagging manual therapy. I'm like, well, give manual therapy a go. But if it doesn't work, what are you going to do then? And the problem is we often don't have backup options. So you can look at short-term pain relief, and the natural history, they may get better anyway. But fundamentally, it is an honest conversation with the patient to go, look, I can't fix your back, but I can take you on a journey to give you strategies to get your life back. And often when that happens, pain doesn't become such an obstacle. And often you will get pain relief in the process, because we saw that. We saw a reduction in pain and disability. And in fact, one of the mediators of a reduction in disability was pain reduction as well. Kind of makes sense. So look, that's probably the overview I would see, is like that willingness to kind of engage in this process is probably one of the key factors.
I guess we've kind of touched on today that CFT did have very good effects in this trial, and very large effects compared to other interventions. Chaturani and Jayden, what do you, I guess, think is the reason why most current back pain treatments aren't working? Maybe we'll hear from you first, Chaturani, from a research perspective, and then Jayden from the clinical perspective.
Yeah, I think the CFT, it addresses each participant's specific pain reliefs, movement behaviors, and emotional responses. So this treatment directly targeted the drivers of the chronic pain. So it's just not like offering a general advice or passive modalities. I think that is the key. So that's why it's that effective.
So I think CFT is effective for two parts, because of the training that the clinician gets, and the very comprehensive training that they can provide and relay onto the patient. And I also think that CFT looks at the patient as a whole, and a whole range of factors that might be contributing to the patient's pain experience, where other modalities like passive therapies might just be looking at the physical side of things, whereas looking at CFT, you're looking at all these biopsychosocial factors and how they contribute.
So yeah, I guess we're coming close to time. It'd be good to hear, I guess, one last question from everyone is, I guess, where to next in this research and clinical space? So what's the next important step in the research world?
Yeah. So I think so we need to think how this CFT can be adapted and delivered in remotely delivered rural settings, either through telehealth or digital first platform. So especially in Australia, we do have rural and remote regions, so we can't target everyone face to face. So it's important to assess the efficacy of these interventions through the telehealth delivery models.
Can I just respond to that? So within the
Yeah.
Restore trial, it was situated during COVID. So in fact, COVID struck just as we were finishing the trial. So we were able to switch treatment to telehealth. And the beauty of CFT is you can. So it's because it is an intervention, it is really around coaching people. You can do behavioral experiments online where you guide the person through a video link. And so it does lend itself to that. And we've got MRO funding at the moment to run a follow-up trial, which is looking at CFT embedded in different care settings. So in the public setting, private setting, and a rural and remote setting. So we're literally looking at remote training of the clinicians as well, because we're interested whether we can deliver training that's not in person, as well as delivering the intervention via telehealth, which we have some evidence that we can, but we want to do that more systematically.
Yeah, I'm also wondering how we can transfer this CFT model to other countries, especially for low middle income country. There will be a lot of challenges more than Australia. So I think it's a good approach, approaching other countries, especially low middle income country settings.
Yeah, I can speak to, I mean, there have been some trials in Brazil, which is a middle income country, and we have within the Evolved Pain Care Academy, it's got the way it operates is it's social enterprise. So people in low income countries pay very little for the training. And so we've got partnerships that we're developing with people in low-income countries because we're interested to see. We've had a lot of clinicians telling us that they're excited about trying to implement this, but we're really interested to see how that will work in those countries. So that's something we're really interested in. We don't know, but it's something that we want to know.
Any final thoughts from you, Joe or Jayden?
No, I mean, just for me, I think that this intervention has made such a big change in my life that I just think that it's really important that this research and this discussion and it just continues, and we try and get as many people on board as possible. I mean, there are so many non-physical drivers of pain that I just think traditional therapies alone won't do the job, whereas this seems to tick all those other boxes as well. So I think just keep fighting the good fight, everyone, because there are a lot of people like me that need help, and this has the capacity to do that. And if you're a patient, I think don't be so convinced that your scan or what you've been told means that you're as damaged as you think you are. Always be open to the idea that you can recover, because I didn't think I was going to get to where I am now, and I'm living the dream.
Like I mentioned at the start, I think it is very reassuring to know that there is something out there that clinicians can look at to know that there is something that works to help address people with back pain. But it's also important to know that it is also a long journey for the clinician. It's not something that you can learn quickly or just pick up just like that. So it takes both a lot of training and work with both the patient and clinician.
But the juice is worth the squeeze.
That's right.
That's a great point to end on.